Once again, good evening to all. As like mentioned by Sister Sheba, I'm Sajan VS. Since 9 years, I am working in Pallium India as a nurse. So today I would like to introduce not a new topic, but an important topic. Basically, we are going to see in our palliative care, ostomy care. Ostomy means what? Can anyone respond? In chat box also you can respond. What do you mean by ostomy?
Please respond.
Okay, it's a surgical opening. Okay, thank you for your response. Actually, ostomy means it's a surgical opening. Naturally, our human body having so many orifices are there, natural orifices are there for the helping the mechanism of our body. As per the mechanism of our body, some of the things our body need to get inside from the environment, and after the mechanism, some of the waste material body needs to excrete out to the environment. So for that purpose, our human body having some of the natural orifices. But according to the some of the disease condition or due to any progression of the disease, some orifices can't fulfill the need of our body. In some their cases, we surgically make an opening. It's basically temporary basis or the permanent basis we doing the ostomies. Temporary basis means if suppose one of the part of the organ or maybe that organ having one disease, for the correction of that disease, some surgical intervention needed. So the surgery done for a time period need rest. Example 6 weeks or for a month need rest for that area or particular organ. In that cases, for a temporary time period, we making another opening to near to that or parallelly to that, we make another pathway. We making rest for the surgery done site for a time period. After the time period of rest or after the time period that we again constructing or we again making the old pathway or repathway to the natural orifice. That's the temporary ostomy. Permanent ostomy means due to the disease condition, permanent basis we surgically removing the organ or we removing the part of the organ permanently. So we can construct a normal pathway to the orifice. So we, as a permanent basis, we making an ostomy. That ostomy will be there with the patient till the death. So when we thinking about the types of ostomies, mainly two types are there: input ostomy and the output ostomy. Input ostomy means, as like we mentioned, body needs something for the mechanism of our body from the environment. So the input ostomy examples are tracheostomy, gastrostomy, feeding ileostomy. These are all the examples for the input ostomy. Output ostomy means after the mechanism, the body need to excrete some of the waste material from the body to the environment. So for that purpose, we making any ostomies means that's the output ostomy. So here two pictures you can see. Can anyone just answer which ostomy is there? First picture which ostomy, second one which? Can anyone just tracheostomy? Second one? Colostomy. Okay, thank you. So first of all, we can just see about the colostomy. Colostomy means what? Naturally, the rectal opening is there mainly for the evacuation of the fecal content. But in some cases, the rectal opening cannot pass the stool, or we cannot use the anal canal or the rectum for the defecation. In some that cases, surgically we will make an opening on the abdominal wall. To the abdominal wall, that opening, we attaching the colon end, inside end of the colon, we attaching to the abdominal wall. As like the rectum, there is an opening will be there, but one thing, there is no sphincter control in that. Only the stoma will be there on the abdominal wall for diverting the colon to the abdominal wall. Through this colon, as like the rectum, the fecal matter, flatus, and the excreted that secretion items, waste materials, not all the things there means also they can excrete through the colon. That's the colostomy. So anatomically, I know you're all well known about the anatomical structure, position, and everything. But just simply, I am just mentioning about the large intestine or the colon. According to the part, there is a four parts we mainly saying ascending colostomy, ascending colon or ascending part, transverse part, descending part, and the sigmoid part. Wherever the stoma is making or colostomy is making, according to the part of the large intestine or according to the part of the colon, the name of the colostomy also will vary. In ascending part, we making the colostomy means ascending colostomy, as like that, transverse colostomy, descending colostomy, and the sigmoid colostomy. So we know according to the physiological function of the large intestine, various parts having various functions are there. The fluid and minerals and electrolyte absorption, full formed bowel content, fecal matter will be there in the sigmoid area, everything we know. So wherever the colostomy we making, according to that, the name of the colostomy will vary. So this one is the actual picture of a colostomy or a stomal picture. And last picture is the colostomy appliance or the colostomy bag. So we moving to the about the colostomy appliance or colostomy bag. Actually, so many types of the colostomy bags are there, but mainly according to the use, we mainly saying the colostomy bag are two types: one-piece method and the two-piece method. One-piece method means along with the bag, the wafer or the base plate, the adhesive area is also will be there with the bag. So that is the one-piece method. Two-piece method means base plate or the wafer will be separate, bag will be separate. So here what is happening is in single one-piece method bag means whenever the bag is filling with fecal matter, we need to evacuate means we need to take completely or we need to peel off completely from the stomal region and we can use another one. But in two-piece method means whenever the bag is filling with fecal matter, we can empty the bag, removing only the bag itself, we can empty the bag. The wafer or the base plate will be there around the stomal region. After cleaning, then we can reuse or we can use another bag on the base plate. That's the benefit of the two-piece method. So here you can see normally the colostomy bag will standardized number will be there. In one patient, the stomal size will be vary. So according to the size of the stoma, we need to prepare the bag. Then only we can use the colostomy bag for the particular person. So along with the colostomy bag, we will get one measuring gauge. First picture you can see on measuring gauge. This measuring gauge actually having so many circles are there. One circle having mentioned as like value, millimeter value will be there. Example 25 millimeter, 35 millimeter, 50 millimeter. So we need to select the correspondent circle to the concerned person's stoma. Accurate size we need to take, we need to select, then place the selected circle on the colostomy back side of the wafer or base plate. We need to circle by using or we need to mark by using one marker pen. Then by using curved scissor, we can cut the base plate according to the that correspondent size. If we choosing 35 millimeter size, that circumference on according to the measuring gauge we choosing means we need to mark it as like 2 to 5 millimeter bigger than the accurate size of the stoma. So here we need to keep in mind too tight and too loose we can't prefer. Accurate accurate size we need to mark it on the base plate. We can cut it 2 to 5 millimeter bigger than the actual size. Then we can use the base plate on the around the stomal region. So as like everything on the physical examination, as like same, here also we need to assess the stoma. Some of the normality and some of the abnormality also we can see while assessing time on the stoma. First one, stomal edema. Actually, the edematous stoma is a normal only even after the surgery. Around 6 weeks time is needed to become a normal stoma. Till that time, in between the edema is normal only, but gradually the edema will decrease only. It will become a normal. That time total we needed 6 weeks. So this actually the stomal edema is normal only, but time after weeks are going, the edema is not at all subsiding means we need an opinion from the surgical department, or otherwise it's a normal only. Then stomal prolapse and the bleeding. Stomal prolapse means normally on stomal picture you already seen. It's a protruded thing. It's like on protruded bulgy surface on the abdominal wall. In some cases, inside the colon part also it's a prolapsing or protruding through the opening to outside. Mild prolapse means by a gentle soft pressure we can give by using our finger and we can rectify the prolapse. But moderate to severe or severe prolapse is happening means we need to refer the patient to the take an opinion from the surgical department. Then only can manage. Another one, bleeding. This prolapse is also mainly happening due to if the patient having severe cough, prolonged sneeze and cold is having. With the stoma, if the patient is lifting the overweight, that condition, due to the surgery, already the abdominal wall continuity is totally lost. There is a gap is there. So at any time, the prolapse chance is there. So we need to educate the patient also. They need to avoid these type of abdominal pressure getting activities. If any cough and anything is means also we need to do the management as soon as possible. Then we can manage. Then bleeding. Bleeding is mainly happening any anticoagulant medication already if the patient is getting, or if the patient having low platelet level, or if the patient getting any accidental injury to the stomal region, then it will cause the bleeding. Then any prolonged use of any non-steroidal anti-inflammatory drug is also, these are all the main causes for the bleeding. So correct the correctable and do the management for the patient. Then parastomal hernia. Parastomal means around the stomal region is the parastomal. Herniation is mainly occur due to, here also, as like I already told, the continuity of the abdominal wall is already lost. There is a surgical intervention only we did and we made the stoma on the abdominal wall. So inside the abdominal wall, maybe the inside gap is there around the stomal region. The inside colon part or nearby any organ part is sticky near to the opening region means there is a chance for the herniation of inside to the outside around the hernial region. So actually parastomal hernia is a complication mainly happening in the colostomy cases. So as like the hernia repair, here also we can repair by using mesh, biological mesh we can use and we can rectify, we can correct the parastomal herniation. But one thing we need to keep in mind, there is a chance for herniation at any region. If suppose one region the herniation is happening means also we can close that area, we can relocate another site. But there is also one chance or there is a risk is there for the herniation. So this one is the retraction. Retraction means normally on stomal look that region how it looks like already you see. But here the outside abdominal wall that bulgy like stomal region is already is a pulled like or inverted inside like on appearance will be there. Normally here the stomal region is retracted or inverted to the inside of the abdomen. This type of retracted cases, around 14 percentage of 14 percentage of colostomy surgery is reporting about the retraction. This retracted cases, not a complication, it's a difficulties there means normal colostomy bag or normal base plate having colostomy bags we can use for evacuating the bowel content for this retracted cases. In these cases, we can use only the convex type of the base plate having colostomy bags. It's a special bag only. Base plate will be in not a flat surface. It will be having convex surface. That type of bag we can use for the retracted type of the colostomies. So another one, peristomal reaction. Peristomal reaction means also around the stomal region, that surface is the peristomal region. That region having some reaction may will happen. Why? Because already I told, while choosing the colostomy bag, we can choose accurate size of the stomal region. Too loose, suppose we choosing means peristomal region having the more visible area, there is a chance for getting contact continuous with the fecal matter and excreting items from the stomal region, that peristomal region getting continuous contact. If suppose the region getting continuous contact with this fecal and waste material means it will cause the skin excoriation or the reaction of the peristomal region. So in this situation, we need to do the proper skin care for avoiding the peristomal reaction. Then suppose if whenever we seeing the patient, suppose having any skin excoriation or if any skin reaction is there means also, we can do the management. So for that part, we going. First of all, we need to avoid the skin excoriation on the peristomal region. So for that, we need to give proper skin care. The stomal region and around the surface also, we can clean by using wash with soap and water. Normal water and soap we can use for washing. And after washing, keep the peristomal region very clean and dry. We leave for some time for the drying. After drying, we can fix the colostomy bag on around the stomal region. Repeatedly, I'm telling, use correct size of bag. Whenever we choosing with the help of the measuring gauge, we suppose 35 millimeter we choosing means that 35 millimeter is accurate size for the stoma. Don't be very loose. Very loose means more peristomal region will be exposed and get chance for getting contact with the fecal matter. It's already inside the bag. Then after filling the bag, 3 by 4 portion is the maximum. Half portion or maximum 3 by 4 portion of the bag is filling with fecal matters. You need to empty the bag. Or otherwise it will cause the overflow. Overflowing the fecal matter means it will get chance for getting contact with continuously with the stomal region and the peristomal region. Then for cleaning, cotton clothes only can use because cotton only the skin friendly material. Then these are all the skincare we need to do for avoiding the skin excoriation. Suppose any skin excoriation we notice means on assessment, then we can do the management as like we can apply karaya powder with the egg white. In home itself we can do. In egg white we can mix it the karaya powder and we can apply the karaya powder mixture with the egg white. We can apply around the peristomal region. Just a few seconds we can leave for drying. After drying, this cotton looks like on filmy appearance. On thin filmy appearance we can see. On that we can apply the normal colostomy bag. So on benefit is there, the colostomy bag base plate, the adhesive material will not directly contact on the skin. In between on filmy on coat will be there with the karaya powder and the egg white. Actually, the karaya is a natural material only, karaya plant and karaya tree. From this tree only we will get the karaya. Commercially, we can get this karaya powder as like this form. So this karaya powder only we can mix it in the egg white and can apply. Then in some cases the colostomy bag itself we will get the barrier cream. They can apply the barrier cream also. It will help to, it will act as a sealing effect around the waist plate. So there is a barrier for getting contact with the fecal matter to the peristomal region. Then zinc oxide also can apply as a substitute for the cadaver on the peristomal skin region. Then any we need to educate the patient and the family. Avoid any use of the powder, any other creams, or any other deodorant items on the stoma or the stomal region. We need to educate them to avoid because it will irritate the stomal region. So, according to the diet, if one patient after the surgery, after the colostomy, we need to control the gas forming foods because here the ostomy, that colostomy region having no sphincter control. So the patient cannot control the gas. So they need to control gas forming food or they need to avoid chili and spicy food they need to avoid. Then control onion, cabbage, garlic, meat, like that smell forming food also they need to avoid. Then we need to control or we need to avoid diarrhea and the constipation. Here, diarrhea, already I told no sphincter control. Whenever the loose stool is happening, means also it will fill the colostomy bag. It's continuously it will come. So that will it will hurt the patient, it will irritate the patient. So before the surgery, which oil they already was using for the cooking, same cooking oil they need to continue for cooking even after and after the surgery also. Then because their bowel is habitual formation already happened due their that thing is friendly with the same cooking oil. So they need to use same cooking oil for the cooking. Then as like same only diarrhea, constipation also we need to manage or we need to avoid. So they need to take use high fiber diet and the fluid intake also they need to increase for avoiding the constipation or manage the constipation. Then traveling time. In traveling time, they need to carry. Ladies means they can use handbag and or any purse or anything they can carry with their hand for protecting the stomach. Because in public transportation system, suppose the patient is using to travel means in between accidentally in crowded situation means in due to another person there is an accidental injury may will happen for the stomal region of the patient. So they need to protect their stoma by themselves by carrying a purse or any handbag. Then extra collection bag, colostomy bag, they need to carry during the long journey time because if they are very much caring about the food means also and during the traveling time due to the food pattern change maybe the chance for getting diarrhea or maybe getting a chance for the frequency of bowel movement also will vary. So in between the bag will fill, so they need to carry adequate bag during the long journeys. Then clothing. For clothing, there is no restriction. Whichever the clothing the patient is comfortable without disturbing the stomal region, whichever the clothes the patient is comfortable means also they can use. No restriction is needed. Then sexual life. The patient and the family have the right to get the love and compassion till the death. So they need adequate support, advice, and encouragement. If any men or psychologically any disturbance for them means also adequate counseling also from our side we need to provide for the patient and the family. Then back care. As like saying the stomal region, colostomy bag also some care needed to continue. First of all, repeatedly telling use correct size of bag only. Then 3 by 4 portion is the maximum only. It's very safest side. Half portion of the bag is filling with fecal matter means also we need to empty the bag. So that thing we need to communicate to the patient and the family. Then for washing and for cleaning the colostomy bag, stone washable and brush washing we can't recommend. Simply we can wash the colostomy bag by using soap and water. Normal water and normal soap can use for cleaning the bag. For avoiding smell inside the bag means also no need to use any deodorant items or any perfume items. They can put on charcoal, a small charcoal piece they can put inside the bag for preventing the foul smell because it will act as antioxidant. Then after washing, after cleaning, you can put the bag for drying under the shadow. Direct sunlight they are putting for the drying means it will cause the cracks. If suppose they are using stone washing or they are using brush also for brushing and cleaning means also it will cause the tear and cut will happen on the back region. So here one patient story just I am showing here. Can anyone just read this patient story?
Hello. Hello, good evening, sir.
Good evening, miss.
Sir, Mrs. T, 45 years, was diagnosed with carcinoma rectum and had undergone sigmoid colostomy 3 months ago. He has been using disposable colostomy bag for bowel emptying. He is a management executive and finds it very difficult to manage it.
Madam, actual question is here.
Hello. What option can you advise him as a palliative doctor or nurse?
Can anyone have any idea?
It's option to nurse.
Anybody have any different opinion? Please respond. Just imagine this patient is sitting in front of you. And he is asking, is there any other option? He is a very
We will
difficult.
advise to palliative nurse.
Sorry, sir, can you repeat again?
Palliative nurse.
Yeah, yeah. You will refer the patient to the palliative care nurse, huh?
Yeah.
No, I am asking which option you would suggest to this patient. Just imagine this patient is sitting in front of you. Rather than reference, just tell your suggestions. So we have to teach patient and relative how to take care at home. So he is able to take care at home, but the problem is he is working as an executive management executive. He is very difficult to manage it. As Sajan told earlier, whenever the bowel move, the fecal matters will come out, and that fecal matter will be collecting with the help of a colostomy bag. So that will be very difficult for him as he is working as a management executive. So he is asking, is there any alternate option do you have? Okay, Manjula ma'am said psychological support. Thank you. Give confidence in psychological support. Okay, thank you. Any other options? Others, please respond.
Okay, thank you to everyone for your response. So here we can give an different option for only for this patient, colostomy irrigation. So why we can use this colostomy irrigation for this patient only? Here the diagnosis He diagnosed with carcinoma rectum and had undergone sigmoid colostomy. So you need to keep in mind only for the sigmoid colostomy, we can suggest the colostomy irrigation procedure for the benefit of the patient. Why? Because according to the part of the colon or according to the part of the large intestine, various part having as a physiological manner, according to the various part, various mechanisms are there. So in sigmoid area only, full formed fecal matter will be there. So in between, maybe in transverse region or descending region or ascending region, if suppose we suggesting the colostomy irrigation means in that area the stool content will be watery or semi-watery, mushy type will be there. In that region, need to absorb proper adequate fluid content, minerals and electrolytes from the bowel content need to absorb. In that region, we irrigating means sudden fluid lossage and electrolyte imbalance will happen for the patient. So full formed bowel content will be there in the sigmoid colon. So the sigmoid colostomy patient only we can use this colostomy irrigation procedure. So why we need to do the colostomy irrigation? First purpose is normally every person having one bowel habits are there. But here the colostomy cases, there is no sphincter control. So no bowel habit we can make for the patient. But with the help of the colostomy irrigation, we can make a habitual formation for the bowel for the particular patient. Then we can, it's a, as like the name only, it's a irrigation, it's a flushing, washing out completely at a single time. So to clean colon, gas, mucus, fecal matter, every waste material, we can clean as like washing, we can flush out completely at a single time. So then we can prevent the skin excoriation also. In between, the bowel content is coming into the colostomy bag means, suppose any peristomal region is exposed means the content will get contact with the content with the stomal region and it will, there is a chance will be there for the skin excoriation. But in this case, totally we washing out, in between nothing is coming into the colostomy bag, so we can prevent the skin excoriation. For the colostomy irrigation procedure, mainly for the irrigation, we using the solution. Plain lukewarm water only we using for cleaning or for washing the bowel. Some instruction also we need to give to the patient and the family before starting the colostomy irrigation. Irrigation, the patient need to do, they need to continue lifelong. Till death, the patient need to continue the colostomy irrigation, mainly the sigmoid colostomy patients. Then after starting the colostomy irrigation, around 21 days is needed for getting the habitual formation. So that thing also they need to keep in mind. Otherwise, even after starting the colostomy irrigation, they are expecting need to get the habitual formation. So we need to explain thoroughly. 21 days is needed to get a habitual formation. Then every day in fixed time they need to irrigate because our main purpose is to make a bowel habit for the patient. So irrigate a fixed time daily according to the patient convenience. So here 3 pictures are there, the colostomy irrigation procedure picture. Some equipments is needed. First one, irrigation bag. First picture you can see one irrigation bag. Inside the bag only we just pouring the lukewarm water. Then one connection tube is there, that in between the tube one clamp is there. By adjusting the clamp only we just adjusting the flow of water. Then on tip of the tube one cone surface is there, that tip. That cone only we just inserting into the stoma. Before inserting into the stoma, by using our little finger, just assess the direction of the stoma. According to the direction, we just insert the cone. That cone surface is not a sharp, it will not cause any injury to the stomal region. It's a soft surface only. You can just insert. Then one sleeve also there. Sleeve having one belt also there. With the help of the belt, we can fix the sleeve. That sleeve having one opening inside. that opening, as like the colostomy bag, on opening is there, it will cover around the stoma. Then the sleeve, it's a lengthy pouch only, that having one inlet and outlet also. Inlet region is we suppose to cover around the stoma. Outlet will be inside the closet or inside the container which is needed to empty or just for the discarding. So whenever the patient is inside the bathroom, means near to the closet, they can sit by using they can grab a stool or any chair, they can sit near by the closet. Whenever after sitting, the irrigation bag they need to clamp at the head level or just just above or at the head level. If suppose they are hanging too much height, means the gravitational force also will increase according to increasing the height of this irrigation bag. So if the gravitational force is increasing, means water flow also will increase. According to the increasing of pressure, it will cause the pain. The patient will feel the pain on the abdomen. So that thing also they need to maintain. So thank you for watching this video also. Have any doubt in this video?
So I hope this colostomy care and colostomy irrigation is clear to everyone. So now we move on to the tracheostomy care part.
Okay. Next, we moving to the tracheostomy. Is an example for the input ostomy. So tracheostomy means what? Normally, one patient or one person is able to inhale and exhale through a normal pathway, but due to this any disease condition, the normal airway is not possible to inhale and exhale. In that case, the tracheostomy we are doing. Tracheostomy is an artificial opening made in the trachea into which a tube is inserted to establish and maintain a patented artificial airway for the patient. So here this picture, the tracheostomy two parts are there. First one steel tape and the second one is the vortex tape. This tracheostomy tube having total three parts. First one outer cannula, next one inner cannula, and third one is the obturator. So here the outer cannula or outer tube is mainly we seeing outside the facing area. We fixing the outer cannula or outer tube by using any tie or ribbon. We around the neck we will tie it and keep it safely. Then inner tube will be inside the outer tube or outer cannula. So I have a question in this area. This outer cannula or the inner cannula, which tube or which cannula have more length? Comparatively, which one have the more length? Please respond for that. Which tube is lengthier?
Please respond. So this picture also you have seen. There is a outer cannula, inner cannula, and obturator. So in the outer cannula, if you take inner cannula and outer cannula, which one is lengthy? That is the question.
Middle inner one, madam.
Inner one. Okay.
Yes,
Is there any reason? Is there any particular reason for that?
Madam, due to length of the esophagus, ma'am.
Okay. Okay, anybody have any other opinion?
So thank you for your response. Here, the inner cannula or inner tube have more length than the outer cannula. It's right answer only. Why? Because the inner cannula only in between we removing or taking outside from the outer cannula. After washing, after cleaning thoroughly, we again reinserting or we will insert another one in the outer cannula. So when if suppose the inner cannula is short means the tip of the outer cannula inside part, the cuff and sputum dried form, it will block the outer cannula. So here actually the inner cannula have more length. So whenever we insert in time, this inner cannula, it will clear the blockage of the outer cannula or it will prevent the blockage of the outer cannula. That's why the inner cannula having more length than the outer cannula. Then obturator, the third part, actually it's using for a gate. While inserting the tracheostomy tube during the procedure, this obturator, the tip blunt surface, along with the obturator, we just inserting the tube, so it will act as a gate for inserting the tracheostomy tube during the procedure. So tracheostomy, already I told tracheostomy tube having two parts. So outer tube and the inner tube. Various parts having various type of cleaning and usage. Outer tube, suppose if the patient is able to walk and patient is able to do the activity means patient only can clean the outer tube, because here the outer tube remains in the outside, that facing area we can see outside. It is placed by a ribbon or it is fixing by using with the help of ribbon or tie. It should not be removed. Every time it will be there around the neck. The inner tube which fits inside can be removed for the cleaning purpose in between. So while cleaning the inner tube, the patient only can clean the facing area. Train the patient to clean the tube self with the help of a mirror. They can sit in front of the mirror and they can see the facing area. They can clean thoroughly without any help. If the patient is capable to sit, means they can do. The inner tube, thorough cleaning of the tube inside and outside with the running water. They can place the inner tube under the running water. They can clean thoroughly. For the sterilization purpose, they can boil in the water for 5 to 10 minutes. After boiling also, they can clean the inner tube by using normal saline. After complete cleaning, they need to just tap thoroughly. Zero water content, so zero droplet will be there in the inside and outside of the inner tube. So they need to ensure that then only they can reinsert the inner tube inside the outer tube. Then outer tube not to be removed by the patient, only the cleaning only they can do. If they need to change the timings, patient can't do, we cannot promote the patient to remove or change the time. Then outer tube cleaning, for changing tie of the outer tube, it is applied to fix the tube in position. Whenever they need to change the dirty old timings, they need to fix completely with a new one. After fixing, need to ensure one finger gap will be there after tying by using the ribbon or tie. Then only after ensuring the proper fixation with the new tie, then only they can cut or they can remove the old tie. This thing cannot attempt by the patient. They need support for the care for changing or removing the tie. Then here also, this also a ostomy only. So here also the skin care is needed. So while taking care about the tracheostomy tube, the site, that stomal region also need to clean by using saline soap the gauze. Then keep the skin around the tracheostomy tube region very clean and dry, because in between the neck region only continuous sweating area or the mucus and sputum things they will sticky around the stomal region. So keep the skin around the region will be very clean and dry. After cleaning thoroughly, they can place the Vaseline gauze. It's a T-shaped cut or V-shaped cut. We can use that gauze with Vaseline. It will prevent the excoriation. It will help the moisturizing effect around the stomal region. So it will prevent the excoriation around the tracheostomy tube. So if the patient needs the suction, even after the tracheostomy, periodical suctioning is needed for a time period. But after that, according to the need only suction they can do. Otherwise, they can avoid. If suppose suctioning is doing means gently need to do very gently, not more than suck at a time, single time 5 to 10 seconds. Within 10 seconds, they need to suck completely and finish it off, or otherwise it will cause the hypoxia. So we need to prevent the hypoxia. So we need to maintain within 10 seconds first suction we need to do. Then for the humidification, sterile gauze piece soaked with, we need to wet it and we can spread it with the gauze piece over the tracheostomy tube. It will help on humidifying effect and it will act as a filter around nearby air, from the air, dust and other flies or other dust particle, it will act as a filter. So that thing also very important. Then tracheostomy patients, they can speak out, but as a therapy basis, we can give the speech therapy. So first of all, they need to inhale, deep breath they can take. Then by using one finger, they can close the tracheostomy tube. Then they can pronounce or they can spell one by one word. So according to that, by practice, they can gain the breath holding capacity, then they can speak out word by word. So it's a completely part of the speech therapy. So even the patient is in tracheostomy also, they can speak as in a training after the complete training. Thank you all.
Anybody have any questions?
If the secretion is too thick, we can use soda bicarb to loosen the secretion, then do the suctioning.
So soda bicarb. When will you use soda bicarb?
When the secretion is too thick, by using the catheter, it will not suck out properly.
Okay.
So we can use soda bicarb injection.
Okay.
1 ml you can add it, then the secretion becomes little loose, then you can suck out.
Okay. Injection you can add where?
And the tracheostomy tube is in the tracheostomy tube.
The tracheostomy tube itself, you will in the push sodium bicarb solution, right?
Yes, yes.
So that I don't know. So I don't have any experience on that. I don't know how many of you have a similar experience, but we prefer we don't push anything into the trachea because the aspiration and cough will be there into that area. If what we do here is we will give a mucolytic agents. If there is a secretion thick, if the secretion is thick, we use medications like mucus that soften like mucolite tablet is available here. So we used to use that medication for softening the secretions. And also nebulization. Nebulization, if you do the nebulization also, that the secretions will loosen.
And the suctioning method also, madam, that selecting the tube and the technique is very important.
Yes, that is also not more than 5 seconds because there is a chance of hypoxia. That is also very, very important. We in palliative care, we don't prefer suctioning. We used to give no pharmacological measures for draining the secretions. We don't encourage that suctioning. Okay, thank you. We can move on to the case presentation. We have very limited time. Mr. Jagat Kaur, it's over to you. Can you able to see the slides?
Good evening, ma'am.
Yes, yes. Good evening.
Yes, ma'am. I am Jagjot Kaur.
Okay.
Yes, ma'am. Today, patient details: age 41-year-old, gender male, diagnosis celiac rectum, presenting complaints. Patient came in the stoma clinic with complaints of itching on peristomal skin. History of illness, history of HCV positive, chronic alcoholic, bleeding per rectum, difficulty, defecation. Examinations, one examinations, abdomen was soft, normal, anal tone, growth present at 7 centimeter from anal verge. Fingertip soft with blood and debris. Colonoscopy shows the growth at 10 centimeter from AV. Biopsy shows adenocarcinoma well diffracted on 11/12/2023. The treatment and the significant investigations plan CT, RT, stoma, constructions done, staging lab plus loop transverse stoma on 25/11/2023. Psychologically assessed due to the eating, patient feel discomfort at the night due to the eating, patient not slept properly. Medications nil. Main concern: peristomal skin cleaning done with the NS, barrier cream and powder applied on peristomal skin. One piece pouch 17501 fixed on transverse stoma. Summary: patient came with the complaints of itching, bag removed, peristomal skin redness present, cleaning done with NS, barrier cream and powder applied on the peristomal skin. One piece pouch 17501 fixed. Patient got leaves from eating after bag changing. Discussions points.
Could you please read it?
Yes, ma'am.
Yes, please read the questions.
Okay. Yes, ma'am. Okay. Thank you.
Thank you for presenting a patient story. Anybody have any more clarification? Anybody need any clarification regarding this patient story? So I think the presentation is clear to everyone. The discussion points, what advice must be given to patient when he or she take bath? Is there any idea? Any suggestions? This patient is on colostomy. Wants to take bath. So she advised to take a bath without apron with heavy bag change. Okay. Any opinions?
So here this story, there is a no contraindication even if the patient having the colostomy for bath. They can take a normal bath with the stoma because already I told for the stomal site cleaning, use normal water and soap we can use for the stomal region cleaning. So same only normal bath they can take.
Yeah, if they take if they wearing double piece method, they can better they can protect the wafer with the cloth. They can cover that area with the clothes so that the area will not be get soaked. If there is any that soak there, there is a chance of getting out the wafer from the colostomy site. So better you can cover the area with the cloths. After that, they can able to take good bath, no problem. If they want to change the wafer without covering the cloth, without covering the stoma, they can take bath so that you can they remove the wafer easily. So the next question is how to make correct measurement of the stoma. So that we already discussed. 3 to 5 mm bigger than the actual stoma or 1/8 of inch larger than the stoma. That is the correct. What to do before fixation of stoma bag? So every time measurement is not necessary, but if there is if you look into the stoma, if there is any the size enlargement or colostomy, the stoma prolapse there, then you can take a colostomy measurement. Otherwise, you can take the same measurement is enough. What step should follow after putting stoma bag? So here, yeah, we all know that, so the main absorption will be happening into the small large intestine, especially salt and water. If you do the colostomy, the salt and water absorption will be minimal. The patients that leads to the patient go to maybe dehydration. So better you can ask the patient to take adequate fluids. Okay. So this patient, I think this patient is having stomal irritation. I think peristomal excoriation. Because of that, this patient is not able to sleep. And that is what I understand from this patient story. So that is also very, very important. So after wearing the colostomy bag, if these kind of symptoms there, the problems there, that will be affecting the patient emotionally too. Okay, especially excoriation, the peristomal skin reaction. It could be mechanical, it could be chemical, it could be fungal. So we have to identify the cause and treat the underlying cause first. And always, as you mentioned earlier, you can apply cream, barrier cream. So after that, you have to wait for after application, you have to wait for some time and remove that cream, and then you can apply wafer. Or you can use a zinc powder also. And another option is karaya powder. So that is also good for peristomal skin reactions. But before that, you have to identify the reason. What is the cause of the peristomal skin reaction, and treat the underlying cause, and then you can use these kind of medications. So our aim is to relieve their sufferings. If you can able to reduce their symptoms, they can able to do well, so that we can able to improve their quality of life. Any other questions? I hope so the questions is clear to everyone. Any other questions there? We will take it. Otherwise, we can wind up the session. Any other questions? Okay. I hope no more questions. Thank you, Saja, for the wonderful presentation. We have learned colostomy care, colostomy irrigation, and tracheostomy care today. I hope this session is clear to everyone. We have learned many things today. Whenever you have seen these kind of patients, you have to apply this principle to care that patients. And also you have to remember the colostomy irrigation is the option for sigmoid colostomy patient, so that they can able to live without much difficulty during the daytime. So thank you all for your contribution. Thank you, Jagat Kaur, for the presentation. Thank you all for your participation.
Thank you, ma'am.
Thank you, Professor Sajan, for the wonderful presentation. Thank you, Jagat, for presenting this presentation. Thank you all for participating. Thank you for facilitating. Thank you. Let's see in the next session.